Hello, everyone. Welcome back to another episode of OSCE Talk. This episode, we're going to be focusing on the respiratory history, and then within that, really specifically, sort of red flags in the respiratory history, and then thinking about things that might worry you for cancer if you met them in a consultation. So, very basically, Peter's going to take us through how to actually do a basic respiratory history.
Yeah, so very basically for these, you'll start with the OPRA framework and you'll use this to go through their presenting complaint. So let's say that's a cough. When did it start? Progression, has it changed over time? Is there anything making it better or worse? Then for associated symptoms, I like to think about, are they coughing anything up? So if they're producing sputum, you want to clarify how much, what's the colour, and whether there's any blood in it, and that's going to be a key red flag. Then thinking about other associated symptoms, is there any chest pain? Is there any shortness of breath? Is there a wheeze? And for each of those, you really just want to go through the OPRA framework. For example, with shortness of breath, and you want to clarify, what's bringing it on. Is it at rest or only on exertion? Is it worse indoors or outdoors? Does it happen when they're lying flat at night? With things like a wheeze, again, you want to know when it's occurring. Is it at night or early morning? Whether it settles on its own or do they need treatment?
Yeah, absolutely. And then we'll also do probably a bit of a systemic history and just go through the systems. So the main things would be thinking about, are there any fevers present? Is there any recent sort of change in their weight or their appetite? Are they more tired than they normally are? All these things are good red flags generally, but specifically in respiratory history, these are very important. Other important ones would be sort of night sweats. And again, you're thinking more about sort of malignancy, and then again, lumps or bumps and rashes, which can all be sort of atypical presentations of any malignancy. I think one of the things we want to mention that was sort of re-emphasized in our uni quite heavily was the importance of a social history in a RESP history, and also the importance of sort of contact tracing and contact. So the big things that were mentioned were sort of, is there any recent foreign travel within a household? Is there anyone else at home that's actually sick or unwell? What is the living situation at home? Is it a house of multiple occupancy? Is there multiple people inside the house who are actually going to be spreading something like TB within a family or within, a close group? Then there's other sort of slightly more rogue things such as birds. Are there any birds at home? And, that's a very specific type of lung disease that can be associated with that. And then other sort of, again, other types of exposure, possibly exposure at work to chemicals, dusts and dyes. And then your very basic stuff like, are they all up to date in their vaccines? And do they smoke at all at the moment? So that's sort of your basic structure of a respiratory history, and we will do an example history later, but we just want to cover specifically then and focus on the red flags for respiratory history. So Peter will take you through some of those right now.
Yeah, so one of the key red flags is hemoptysis, coughing up blood, and that's always concerning, and it must be asked directly in an OSCE, even if the patient doesn't offer themselves. Next, thinking about the duration of the cough, if it's going on more than around 3 weeks, that should raise concern and usually warrants investigation. Type of cough can be important as well. We often worry more about a dry cough, but if the patient's coughing up green sputum and you've been treating an infection and that doesn't resolve, or they keep getting recurrent infections, that can also be a sign of lung cancer, so it's important to look out for. Hoarseness is another important symptom. If it's lasting longer than 3 weeks, that's a red flag, and you normally need to do a 2-week wait referral for that. Chest pain can also be another important symptom, and it can be a sort of atypical sign of something going on in the chest. Don't forget, you can always ask about changes in the hands or nails. While finger clubbing is often picked up in examination, patients might report these changes themselves. And following on from that, you can also ask if they've noticed any lumps or bumps, particularly around the neck. Most of these things you'll pick up in your examination, but you can always ask it in the history as well. And then finally, just general red flags that you're going to want to cover in most histories: any unintentional weight loss, night sweats, fevers or rigors, and any skin rashes or changes.
We also want to have other differentials for our red flag questions. So why are we asking these questions? Well, is this something such as malignancy or a cancer, or are there other things that could cause things like hemoptysis, weight loss? There are so things like TB and other sort of rare infectious causes. This is something that's becoming more common in Northern Ireland and just throughout the UK, and that's where your social history really comes in. Other sort of less common diseases such as bronchiectasis as well can be involved, where you'll get sort of long-term productive coughs. You might get hemoptysis, you might get chest pain, and you might get weight loss. And again, that's all just due to bronchiectasis and as a non-malignant cause. And pulmonary fibrosis, again, sort of a longer-term dry cough. You might notice some added sounds in the chest, some fine creps, and they'll have quite significant weight loss and difficulties breathing. And again, can present very significantly with patients, and they can be quite unwell with this. So this is something that, again, will require, chest x-ray, CT, and will be actually quite a similar workup to cancer. And then finally, other sort of infective causes, we were thinking, patients maybe with HIV who have pneumocystis, pneumonia, things like that. And then obviously, you're thinking about that, about cancer as your main differential. If you hear those symptoms, that's going to be your top differential. So if you come across a patient with any of these symptoms, you're going to be thinking about what is the next step in management. So let's say we're in a GP setting, and this is a really common presentation at a GP. We just need to go through our basics. We'll do our basic examination, like Peter said earlier. Examination of the lymph nodes, especially the neck, is really important. The neck and axilla are common areas of spread, but obviously that can be raised for other reasons. That could be just due to local infection, COVID, things like that. Slightly sort of more complicated tests, obviously your basic set of bloods to look for infection, but then do you need to send off maybe a sputum sample if there is any sputum? Is there any need for a viral throat swab if you think this is sort of a post-viral or a viral cough? Then you might think again, maybe do they need an urgent red flag chest x-ray? And there are really good guidelines on the British Thoracic Society for requirements for a chest x-ray. And it normally is sort of over the age of about 40 to 50 with any of those red flag symptoms for more than a number of weeks. But again, just look those up and stay up to date with those before the OSCE. And then finally, sort of again, rarer would be things like TB testing. So that's just sort of the basic investigations. And if you can honestly just say a few of those, you'll be doing very well.
Brilliant. Yeah, so that was just a quick overview of respiratory history. So now we're going to move into an example, sort of red flag respiratory history that you might come across in your OSCEs. We're going to follow the same format as before, and the brief for this one will say something like, this gentleman has come in to GP to speak to you about his cough.
Hello, my name is Matthew Pettigrew. I'm one of the final year medical students. Do you mind if I just check your full name and age, please?
Hi, my name is Mr. Rafferty, and I'm 65.
Okay. Mr. Rafferty, do you mind if I ask you a few questions about your health, how you're feeling today, and why you've come into the GP?
Yeah, no, that's okay.
Okay, and how are you feeling today?
Oh, I've been having a cough now for a bit.
Okay, can you tell me a bit more about that cough?
I've been having a cough now. This could be going on about 8 weeks now.
Okay. Is there anything that you can think would have caused this cough 8 weeks ago?
No, I originally, I thought I had a course of antibiotics for it,
okay.
But it hasn't helped and it's never went away.
And over the last sort of 8 weeks, has that changed at all, that cough?
Yeah, so I think it's getting worse. And I can't shift it.
Okay. And are you coughing sort of all throughout the day, or is you getting sort of periods where you're not coughing?
No, coughing all the time.
I ask, are you coughing at night at all?
I am, yeah.
You are coughing all night. Okay. And can you think of anything that would bring that cough on specifically?
Not really. Suppose if I tried to go out for a brisk walk, it would get worse, but...
Okay. So exercise then?
Yeah.
And anything that would take the cough away, or you find inhalers or anything that might help?
No.
And, when you're coughing, are you bringing anything up at all with that?
I'm bringing up a bit of stuff, yeah.
Okay. What sort of colour would that be?
It's like a whitey brown sometimes.
Whitey brown. And has that been for the full 6 weeks?
So, yeah, more or less, yeah.
More or less. And is that every single day?
Yes.
And how much would that actually be that you're bringing up?
A couple of teaspoons, I'd say, a day.
Okay. I have to ask this as well, are you coughing up any blood at all, Peter?
Yeah, I am.
Okay.
Yeah.
And has that been all throughout the last weeks, or is that just recent?
Yeah, that's kind of worrying me. Yeah.
Okay. Look, I completely understand, and I can understand that might be a bit worrying for you, but I have to ask a few more questions just so we can figure out what the right plan will be, okay?
Okay.
Do you have any problems with the breathing at all at the moment?
Not really, no.
No difficulties breathing when you're lying down in bed or waking up at night or anything?
No.
Any sort of pains in the chest at all?
No.
No. Or any feeling of fullness in the chest or the neck?
No.
Any funny noises while you're breathing, sometimes called a wheeze, like a high-pitched noise?
No.
Have you noticed any change in your weight at all recently, Peter?
Yeah, I think I have lost a bit of weight.
Okay. When you say a bit, would you know any numbers or anything?
I'd say, I think I've lost a bit of stone.
Over how long do you think?
2 months.
Right. Okay. And was that on purpose, or is that just being by accident?
No, I haven't. I wouldn't be that heavy as it is, and no, I'm definitely not trying to lose weight.
Right. Do you feel more tired at all recently?
Yeah, I am.
Okay. And how are you sleeping at night?
I'm sleeping. The cough's keeping me up, but I'm sleeping okay.
Okay. Any sweating at night at all, Peter?
Yes, actually, I have been.
Okay. Okay. And would that be sort of soaking through the bed sheets or anything?
I wouldn't say it's that bad, but definitely, I've woke up a few times actually. Now that you mention it, yeah, hot and sweaty, yeah.
And any temperatures at all at the moment, Peter?
No.
No. Or any lumps and bumps anywhere in the body that you've noticed?
No.
Peter, can I ask, do you live with any conditions at the moment?
I've always had a bit of a bad chest, but not really.
And is that asthma then?
No, I think it's more from the smoking.
Smoking. Okay. Would you have a history of COPD at all?
Yeah, I don't come to see the doctor much, but...
And anything that runs in the family at all, Peter, specifically to do with the chest and the lungs?
That's what, my mum, unfortunately, she had lung cancer.
I'm really sorry to hear that, Peter. Can I ask what age that was at?
She was 72.
And can I ask, did she undergo treatment for that? Or?
Yeah, but she passed away. So
Really sorry to hear that, Peter. Look, I can understand that must be stressful for you at the moment.
yeah, and that's was where I'm made, to be honest. Yeah.
Look, I want to say I'm taking this really seriously. I want to do some investigations today and definitely have a listen to the chest as well. And I think maybe sending you for a scan might be the right thing to do, okay?
Okay, thank you.
Just have to ask you a few more questions, Peter. Do you take any regular medications that are prescribed?
No.
No. Any inhalers or anything?
No.
Any allergies to anything?
No.
Do you currently smoke at all, Peter?
I do. Yeah.
Okay. And what would you smoke?
I've been trying to cut down. I'm down to about 10 a day, but I've smoked 20 a day for a long time.
And how long would you say that is?
30 years.
Okay, Peter. And you would consider maybe cutting down then?
Yeah, I do try, but it's hard.
Okay, well that's something we can maybe talk about in the future. Peter, do you work at all at the moment?
No, I'm retired.
You're retired. Would you have ever been exposed to any dusts or dyes or anything?
Not really.
I have to ask this. Would you have any sort of tropical birds or pets at all at home?
No.
No. And anyone else that's sick at home?
No.
Any recent travel with anyone?
No.
Peter, can I ask, do you have any sort of main concerns or ideas that you feel like I've not picked up on so far?
No, just really, my mum's history is just, I don't come into the doctor much, so definitely enough to bring me in. Like.
Absolutely. Look, I'm really glad that you're here today. What I want to say is that, I just want to summarize this to the examiner, and I'm happy to answer any questions from yourself or the examiner.
Okay, Matthew, I thought that was a really good history. I thought you covered all of the red flags really nicely and you picked up a lot of them. I thought you covered social history really well and you covered all aspects of it. I thought you also covered really well how this was impacting the patient. And I thought this was a good history to really bring out the empathy. You picked up on the concerns of the patient really well.
Yeah, and that was something we talked about sort of at the start, was just about that if you come across difficult scenarios, things where people mention cancer, it is just taking those extra few seconds really just to address them. And I think, my favorite thing to say is what the truth is that it's probably too early a stage to say anything about what the actual diagnosis might be. I want to ask a few more questions. If you are worried about it, I think it's totally reasonable to say, I do have some concerns about how you're feeling at the minute, or it's not normal to feel like that for this long. And then you can sort of highlight maybe, I can see that you're worried about coughing up blood because that is a worrying symptom, or I can see that you're worried about having such shortness of breath or a cough for this period of time. So just picking up on some of those worries, understanding them, and then sort of saying that we're going to work through it, and hopefully we'll get an examination done, and we'll sort of refer on for any tests that are needed and maybe get imaging and things. And that's really nice. It's really reassuring, and I think a lot of times for patients that's their main worry coming in, and especially for obviously Peter in this scenario was coming in with a relative with cancer. So it is really just important to address that and not dismiss it at any point.
Mm-hmm. I think the only other point I have is in terms of that social history. If at first year level, it's really important to ask all of those questions because you're getting the basics. I know at our university, we've had lots of final year stations where it's a RESP history, but the diagnosis is more difficult rather than this type of more straightforward lung cancer. It often is a TB. And if you don't get into the basics of asking this at this level, you will forget about it and you will miss those points when you get into those final years of medical school, and it actually could lead to you missing the diagnosis.
Yeah, and the other thing to say is that this probably won't be on its own. At a first year level, they might even add in some imaging. So it could be a chest x-ray, it could show a lung cancer, or just something that you're not quite sure. And I think it's just being able to pick up on that. Other things that they could show is pulmonary function testing. So, an obstructive or restrictive problem. So that'll be really important. Other things that we've seen ourselves are sort of blood results, hyponatremia secondary to, SIADH lung cancer. Sort of there can be slightly strange things, and it's just about thinking about that. But if you have that really solid structure, that'll sort of carry you the whole way through. And, if you learn it well at first year, you can do it well in third year, and you can do it well at the end of the 5 years.
Oh, absolutely, I agree.
So that's us for today, and we're going to continue on sort of the theme of respiratory history taking, but that was just the red flags for respiratory history taking today. Thank you very much for listening.
Thanks, guys.